Hi, this is Dr. Kevin Windisch from Sparks Pediatric and Adolescent Medicine. Welcome to our video series for professionals. We can be reached at our office at area code 775-359-7111 if you need to schedule a clinical rotation or would like to have a patient seen by us. We're in Sparks, Nevada. Please remember this video series is really intended for professionals and professional students such as nurse practitioner students, physician assistants, physician assisting students, medical students, family doctors, emergency room doctors, and so on. Today, we're going to talk about a very, very common chief complaint in my office, and that is constipation in an older child. And by an older child, I mean someone relatively over the age of 2. The common presenting complaint is actually abdominal pain. Many times you can feel stool in the descending and sigmoid colon, or you might feel hard rocks throughout the abdomen. The abdomen should be soft. Tense abdomen suggests there's something else going on, and that being the case, you definitely need to evaluate this further. If the child has a history of constipation from birth, please don't forget about congenital diseases, including Hirschsprung's disease. Remember, if you're ruling out Hirschsprung's disease, you need an unprepped barium enema. Not a prepped barium enema, but an unprepped barium enema. And in a lot of communities, the hospitals will try to get you to prep the kids ahead of time, and that'll make you miss your transition zone. So make sure it's unprepped. First thing we want to talk about is a brief differential diagnosis. Realize that the differential diagnosis of constipation is huge. And we're talking again about older kids, not newborns and early infants. Differential diagnosis includes functional fecal retention and stool retaining behavior, and that's probably number 1, number 2, and number 3 on the list. Additional things, however, can include and need to be ruled out. Things such as sacrococcygeal teratomas. This can be ruled out with a very thorough physical exam, including reflexes of the lower extremities and ankles, and looking at the child's anus. If the child has a gaping petulant anus and poor sphincter tone, you do need to consider that there's some kind of problem with the nerves. Ectopic anus, not as rare as you might think. Structural defects of the anus itself, including tumors such as rhabdomyosarcomas that are impinging upon the anus itself. New onset diabetes. The child becomes dehydrated from the tremendous urine output, resulting in constipation. Changes in diet, low fiber in the diet. Hirschsprung's disease we've already kind of talked about, and something called chronic intestinal pseudoobstruction, sometimes called megacystis microcolon disease, can absolutely do this. Usually these children present from birth, but stranger things have been known to happen for both the Hirschsprung's and the chronic intestinal pseudoobstruction. And if you've never heard of chronic intestinal pseudoobstruction, let me suggest you do a literature search. Search for Dr. Prem, P-R-E-M, P-R-I is the last name. First name is Prem. He's from UCLA and has a tremendous paper describing this. The paper goes back to, I think, the early 90s, but it's one of the first papers that describes this entity, and it's not as rare as people think. It often is misdiagnosed as Hirschsprung's disease. Your physical exam needs to include a thorough exam of the belly. At some point in time, you actually need to look at the child's anus, make sure it's where it belongs, that there are no fissures, no skin tags, no sinus tracts around it, that everything's structurally normal. Most of the time, you don't need a rectal exam. If the child fails to respond to appropriate therapy, if the history is weird, if things aren't making sense, or you have a history that this has gone on from birth, then a rectal exam is important. But many times it's not important, and many times it's in your best interest not to conduct a rectal exam, because these children already start to have issues with that part of their body, and if you start sticking things in their rectum, it just feeds their stool retaining behavior and actually makes things worse. The constipation then needs to be treated, and treated aggressively. Under-treatment of constipation early on results in lifelong constipation, lifelong difficulties with stooling, lifelong abdominal pain, and might result in hospitalization. If you are aggressive from the beginning, you can avoid a lot of this. And the biggest problem I see in my office is inaggressive or unaggressive or not aggressive enough therapy. So being aggressive is very important. I recommend a threefold strategy. First, you have to clean the child out. We'll come back to how to do that in a second. Then you need maintenance medication, you need dietary changes, and behavioral changes. So we'll start with clean out. You can affect a clean out with almost anything. Enemas only clean the sigmoid colon out. You have to be careful if you're using enemas. Repeat phosphofleets enemas risk hyperphosphatemia, which can result in seizure. Soap suds enemas, bad idea. That's an old-fashioned treatment. Results in hypotonic seizures. You need to clean the entire colon out. What I personally recommend for my patients is Miralax or Glycolax, so polyethylene glycol. I recommend large doses of it, large enough to cause diarrhea. Depending on the age and the weight of the child is how to dose it, but don't underdose it. Harriet Lane Handbook for House Officers, in both their 17th and 18th edition, is pretty good dosing guidelines, but again, make sure you're using large doses. So for an older child, 5, 6, 7 years of age, typically, and again, this depends on the age, so don't dose necessarily based off of this, I'll give 2 scoops, which is a heaping tablespoon, a day, and I'll do that for roughly 5 to 7 days. It does cause diarrhea, but you must get all of the hard stool out. I don't like using Senna. I don't like using milk of magnesia because those both risk causing laxative dependence. Not a problem with Glycolax or Miralax. Okay. Once we have cleaned the child out, we then need to begin our maintenance therapy. Maintenance therapy is high fiber diet. That's the dietary change. High fiber diet is defined as age plus 5 grams of fiber, and the parents must count grams of fiber. If at the end of the day the child doesn't have enough fiber, I recommend fiber supplements. Number 2, behavioral changes, assuming the child is already reasonably continent of stool, taking into account that they may be having some encopresis. Child needs to sit on the toilet 5 minutes twice a day after breakfast and after dinner. This takes advantage of the gastrocolic reflex. If the child needs to stool at that time, they can. If they don't have to stool, they don't have to. We can't control when the child passes stool. We can control when he sits on the toilet. And I recommend 5 minutes, and only 5 minutes. Set a timer. Twice a day. Okay? And then number 3 is ongoing medication therapy, which is roughly 1/3 to 1/2 the dose of the Miralax that you used for clean out. That needs to be continued for a minimum of 6 months. Remember that the intestines are stretched at this point in time, and they've been stretched for quite a while before the child came to see you. The child is typically constipated for 6 to 12 months before presenting to the doctor. The intestines will shrink down over time, but in the meantime, the muscularis doesn't work quite right, the nerves don't work quite right. The children, when the stool enters the rectal ampulla, they don't have the sensation of fullness, and they don't have the muscle control to push the stool out. So you need to keep it pretty soft and kind of runny for a minimum of 6 months. After 6 months, you can do a trial off. If the child becomes constipated again, I would reinitiate a clean out and do another 6 months of maintenance, and I would continue 6-month trials with clean out beforehand until we can finally effect a clean out and a 6-month trial, and then take the child off without becoming constipated. During the maintenance phase, if the child becomes constipated again, has hard stool or no stool for more than 24 hours, I recommend a minimum of a 3-day clean out. It's kind of a mini clean out to get rid of that hard stool before the child backs back up. If you stay aggressive, you stay on top of this, you won't have problems. There is a reason why Sigmund Freud thought that constipation was related to behavioral problems, i.e. the concept of anal retentiveness. Okay? These patients who are allowed to stay constipated for long lengths of time have issues. Let's prevent them. This is Dr. Kevin Windisch at Sparks Pediatric and Adolescent Medicine. Our number is 775-359-7111. We'll see you next time.